email with screenshots. So you should know. Yeah. And did you go share the screen?
And we're going to use this screen.
And you hit record. I think you've done that. Yeah.
Here are.
And you know the Telby guys have started because you wouldn't see them. Like they obviously haven't got their camera. Yeah. If they flick to the camera at the top there, you'd be able to see them because they've got the newer. They've got one of those computers which has an inbuilt webcam. So all you have to do is like slide it, and then you could actually see them. But obviously they don't want to see them, so they've just not done that.
Okay. Got it on that one.
You can chat the video if you want. Like, you don't have to have the video going, but what you want to do is you want to share the screen so they can see what you're see, and you want to make sure that the sound is going, which, like, yeah, obviously going on that screen. Recording screenshot. Oh yeah, the other one.
It's already recording now, isn't it?
Yeah.
That little dot.
Which screen does it show? You choose it when you go share screen. So you can't show two screens, but you can say which screen you want to see. And so do they can choose whether you see the screen plus what's on the webcam? No. Okay. They can see what we show. If we turn off the video, then they can see that. If we turn it on, then they see both the screen and so it might always be better to show them that screen because otherwise they see. Like,
yeah, we saw that the other day.
Yeah.
Which is fine.
So if you go stop share, and then click on it again, and choose the other screen, so like it's showing you which screen you're going to pick. So if you, to that time, we must have clicked this screen, which is, so, yeah.
Cool. And then how do you start the recording? It's already recording.
Amanda clicked that.
Okay.
There was a start.
Cool.
Yep. And then you know because that little red dot is there, so that red dot would have gone, wouldn't be there. Because it's the free account, it records to the local computer, it doesn't record to the cloud. If you ever upgrade to that account, then all your recording is in the cloud, you've got 60 days to change it. Can you bring that back with you?
Yeah,
for your room? Yeah, just leave a Sandy outside. And you can just forward it. Yeah.
Alright guys, might get started. Today is Airley. I'm managing Overdose.
Hi everyone. So as Carl said, I'm Airley and I'm covering managing insulin overdose. I came across this topic because while I was on my ED rotation, there was a patient who came in with an insulin overdose, so intentional insulin overdose, and that prompted me to read a little bit more about it. So in terms of this patient, she was a 27-year-old female who was brought in by ambulance with hypoglycemia. She was having seizures, or they weren't sure if she was having seizures or the psychogenic non-epileptic seizures, PNES. She'd had a collapse on a tram, and that's where she'd been picked up. Her BSLs were found to be 3.6 with Ambulance Victoria, and she was unable to be treated because they couldn't get IV access. She had a further seizure in the corridor here at the Austin. And her BSLs were found to be 2.9. This patient had a history of these psychogenic non-epileptic seizures. She had a history of asthma, bipolar disorder, and she'd actually had multiple similar presentations at the Northern Hospital and at the Austin. As far as we could see, she actually had no history of diabetes, but she was found with these 2 Lantus Solar pens in her bag, so it's up to 600 units of insulin potentially. And they were also unsure if there was, if it was polypharmacy overdose because there were other medications found in her bag. However, the screening for those ones came back negative. So in terms of insulin, very basic, broad. So it's released from the pancreas in response to high blood sugar levels, and it stimulates tissue cells to take up glucose from the blood, lowering the blood glucose levels. It also stimulates the formation of glycogen by the liver, lowering those blood glucose levels. And then the opposite of that is the glucagon, which is the reverse. In terms of the presentation of an insulin overdose, so patients who present will usually have autonomic symptoms, including nausea and vomiting, diaphoresis. They can have tachycardia and palpitations. They can also have CNS symptoms, so agitation and tremor. There can be confusion, visual disturbances. They may have seizures, such as this case study patient did, as well as coma. This presentation can also easily be mistaken for alcohol or drug intoxication. And in terms, prolonged hypoglycemia can cause permanent brain injury and death. However, if it's treated quite quickly and quite rapidly and appropriately, it actually can have very, very good outcomes. This hyperinsulinic state can also persist for a significant period of time, more than 3 days, and matter the form of insulin that's injected. So just in terms of sort of toxicity of insulin, it's interesting that there's no real dose that's been identified or anything like that is, say, toxic or safe in terms of overdose. It's a lot to do with the management of the patient, as well as if they're already they're type 2 diabetics, so got insulin resistance as well. That can affect how they recover. This was just sort of a summary talking about the range of doses that could be injected in the form and the recovery of patients as well. Huge doses. So in terms of when a patient presents with intentional insulin overdose, I suppose some key considerations about the presentation is whether or not it was a deliberate self-poisoning, and then to some extent, I suppose, the amount that was then injected. It's also important to consider the fact that the duration of hypoglycemia can last for days. And it's not something that, if it's an intentional insulin overdose of high doses, it's not something that's really going to just resolve, you know, with the administration of glucagon or anything like that. The severity and the duration of it can be very unpredictable. It's not dependent on the formulation. The pharmacokinetics of the insulin type go out the window a bit at these high doses, and also the severity can correlate poorly with dose injection and depend a lot on patient factors and how they're handled. It's important to consider central venous access for these patients rapidly, as if they're going to need the higher dose IV glucose, then higher strength, high concentration, then you're going to want that central venous access as soon as possible. So as soon as you're starting to get them stabilised, starting to think about getting that central venous access. In terms of monitoring when the patient first presents, so you want to be doing serial blood sugar level tests, so every 15 to 30 minutes during that initial resus phase, and continue that regular monitoring until it's been stabilised within a normal range for at least 4 hours. After that, you can reduce it to hourly and then 2 to 4 hourly. That's as per our the Austin Health toxicology guidelines. You want to be monitoring for hypokalemia, hypophosphatemia, and hypomagnesia. These electrolytes can all the electrolytes can be significantly affected by the hyperinsulinic state. With hypokalemia, it's important to note that that the hypokalemia can often be a function of distribution, and actually aim to maintain low to normal potassium levels rather than going too high, because there can be instances of rebound hypokalemia as the potassium redistributes later. You can monitor insulin blood levels, however, blood levels actually don't really predict the magnitude or the duration of how long the patient's going to need glucose and how much they're going to need. They can be used more in a sense of trying to determine whether or not it's an endogenous hyperinsulinic state, and using the C-peptide to assess for this is also useful. So that C-peptide will only be raised if it's an endogenous source of hyperinsulinemic insulinemia rather than exogenous. These endogenous states are very rare. They can come from things like insulinomas and pancreatic cancer, and as well as insulin autoimmune syndromes can cause it as well, but they're very, very rare. So in terms of looking at the initial management, so you want to make sure that you've got resuscitation facilities, you've got supportive care, and you've got close monitoring. If a patient's presented with a significant insulin overdose, you're unlikely to be going down that asymptomatic and BSLs above 4 sort of pathway. You're going to be looking more at these, that area highlighted in the pink. So when the patient presents, as an adult presents, you'd be looking at giving them a 50 ml bolus of 50% glucose IV, and you'd be wanting to commence an IV glucose infusion at 100 ml per hour. That can be administered peripherally, and you'd repeat the boluses as necessary. So you're, if the patient's BSLs drop below 4 again, if they're showing signs of hypoglycemia, you would then re-administer these IV boluses. If you're still struggling to get BSLs consistently above 4, then that's when we'd start to look at titrating a high glucose infusion, which would require the central venous access. So your infusion concentration and the rate, which I'll go through in a little bit, are titrated to maintain a serum glucose between 5.5 and 11 millimoles per litre. So you're aiming a little bit higher than you normally would see, just because they can then drop back off again quickly. You'd also be wanting to monitor serum potassium and continuing to supplement that to keep it in that low to normal range, as I mentioned before. And then the children, it's more dosed on weight, but it's still the same concept about doing those bolus doses, commencing that infusion, and then titrating your highest concentration infusion. This is just coming from the Austin management guide, the Austin toxicology guideline, just sort of what you'd look up if you saw it, but it's what I've just discussed about the infusions and the boluses, and commencing those high dose infusions if necessary. So in terms of titration, so this was for this patient, the case study patient. So she was about 12 hours post her presentation to the ED, and at this point in the last 4 hours, she'd been administered 3 boluses of 50 ml, 50% glucose, and she had a baseline infusion of 100 mils per hour. So in terms of grams of glucose per hour from her boluses, she was getting approximately 18.75 grams per hour, and her baseline infusion was her 10 grams an hour. So if you average that over the 4 hours, it comes to nearly 30 grams per hour. So then from there, they would look at starting a 50% glucose infusion at 60 mils per hour to maintain that. These infusions can get really high, so it can get as high as 120 mils per hour. And when you start getting to those really large volume, it also needs to be consideration about the amount of fluid that the patient's taking on as well. So in terms of administration, as I said, the glucose 50%, it's hypertonic. It will cause pain, irritation. So we want to get it through central venous access. And then, yeah, that's just from our administration guidelines. Anyway, so in terms of, continued, so you've got your patient on a glucose, this higher dose glucose infusion, you're starting to manage their BSLs within that sort of 5 to 11 range. But for these significant insulin overdoses, several days of IV glucose administration is usually required. This can be compounded by the fact that as you've got this high dose glucose infusion, patients who aren't diabetic are then going to be producing endogenous insulin in response. So then it can actually be quite hard to wean these patients off, because you've got the endogenous insulin as well as, still trying to clear that exogenous insulin. So as a result, withdrawal should be very gradual. And it's also important not to do it at night. So if patients are asleep, it's harder to assess those signs of hypoglycemia. There's usually less people around, harder to manage. They're not eating as regularly. All those sorts of things are important to consider. As well, so patients who are diabetic and have those levels of insulin resistance will have reduced counter-regulatory response, and that as a result they may require those increased glucose replacements. There should also be consideration of oral carbohydrate intake. So for the case study patient, they on day 2 they got her onto nasogastric tubes with oral carbohydrates. Also, it's important to make sure that after they've received IV glucose, that patients should always be observed for at least 4 hours as a minimum. So for a case study patient, this was her trajectory through ICU. So the first part of day 1 was spent in the ED, where they titrated her glucose infusion, a high-dose glucose infusion. And then from there, she was transferred to ICU, and you can see that her blood glucose levels were relatively well maintained within that 5 to 11 range with a few peaks. But then she also had they'd increased her infusion up to 80 mils per hour. So high again, and then you can see over day 2, they started to wean that back off, so 50 to 40 to 30, and her feeds also commenced at day 2. On day 3, continued to wean, but she actually self-discharged on day 3 in the afternoon. They stopped the insulin, so not ideal in terms of monitoring post-infusion, but patient discharged against medical advice. So some other management things which I won't go into too much, but were discussed in context of this patient. So there's a few case studies where they'll actually excise the injection site if they can find it. The evidence for it isn't too great, but it's a consideration, particularly with the longer acting insulins. Octreotide is indicated for the use of sulfonylurea overdose, not so much insulin. But interesting to consider how it could also be used in terms of reducing endogenous insulin secretion. As I mentioned before, that can make it difficult to wean patients. So by suppressing that, it can be easier to wean patients. And then glucagon, which isn't really particularly useful in patients with such severe insulin overdose, because the duration of action isn't very long, and it needs the glucose infusion to manage it. So in summary, deliberate self-administered insulin overdose can cause profound and prolonged hypoglycemia, but if it's managed well, then prognosis is excellent. So it's important to get that early effective glucose replenishment. As I said, commence IV glucose infusion early. We want to monitor blood glucose levels frequently and replace potassium as well as the other electrolytes as well. But just with the potassium, again, making sure that we're not aiming too high because of that risk of rebound hypokalemia. And then due to pharmacokinetics, it's that prolonged hypoglycemia. It's unpredictable, and when we're withdrawing the glucose, we need to do it slowly, and we monitor closely, and we don't withdraw it at night. Key references, and yeah. Sorry, that's short. Any questions?
With the glucose infusion, are there any restrictions on where it can be given?
I'm not sure. I'm sorry, I didn't. I think if you're given how close you need to be monitoring. I know these patients are usually in ICU, yeah. The octreotide. that'd be a clean farm approval for that one. So because this one isn't actually indicated for insulin overdose, so there's actually some references, I think it was the BMJ actually say it's contraindicated in the management of insulin overdose. As far as I'm aware, but there's case studies of them using it, and there's instances where they use it. And this patient actually did use it, but they did use it for this patient. I think it was 50 micrograms BD. But I needed to call toxicology and kind of confirm where they got their information from, and I just didn't get a chance. But I can find out and send more information around. I mean, it makes sense why you would use it. It's just, it's not indicated for that. And as far as I can see, there's not really any guidelines available for its use in insulin overdose.
Yeah, there's some considerations in giving a patient like needing a critical line in a central line potentially, someone who's had an intentional overdose. I imagine that the patient self-discharge can be quite difficult in managing them during the hospital stay. Are there any other treatment modalities that we need to consider?
Well, this patient, I mean, they did remove all of that before she was discharged.
There's any oral treatment apart from giving food that they can use so they don't need to have critical or central one.
For patients who have had these huge insulin overdoses, it's usually glucose infusions, the high dose glucose infusions to manage it. And then, yeah, getting the nasogastric tubes in and things like that in terms of, there's not really, as far as I'm aware, there's not really oral medications to kind of counter it when it's like this, because it's just so, it has to be so finely tuned to how the body's responding and, yeah, how the, you know, minute by minute insulin, blood glucose levels, sorry.
Do they, do they normally have done something beforehand before they get a central line in? So
they'll start the 100 mil per hour, the lower dose one.
That's the week at 5%.
Yeah, 10% glucose infusion at that 100 mil per hour, which can be given peripherally. And then, yeah, so from that infusion and the bolus is required, that's how you calculate the rate at which to run the higher dose one, yeah. The highest concentration. Thanks.